Hello, hello, hello. Uh, Good morning, good afternoon, good evening, depending on where you are in the world. This is the Unboxing AI webinar, episode number 45. Yes, we have been able to do this for almost 45 weeks in a row. And, today we have with us good friend, collaborator, Dr. Imon Banerjee. Thank you, Imon, for joining. Means the world. Um, and before we dive into our conversation with Imon, um, for those of you who are tuning in for the first time, this is CARPL's attempt at unboxing AI, where we call our friends, collaborators, customers, partners to come and tell us something about AI that we didn't know before. And feel free to ask questions. We will prioritize your questions over our own deliberations and discussions. The whole idea of doing it as a webinar is that we don't want us to just keep talking, which we can for hours, but we would love your questions. And for those of you who don't know what Carpel is, well, we are your friendly neighborhood AI platform, connecting the whole world of AI applications on one side to your clinical workflows on the other. We allow you to build, test, deploy, and monitor any kind of radiology AI in your clinical workflow. And we serve as a single user interface, single data channel, and also a single procurement channel. So that is enough of shameless self-promotion. Let's get on to Imon. Imon, quick intro. She is an associate professor and director of AI innovation at the Mayo Clinic in Arizona. I just learned that her team has 40 people. Uh, so you have very strong HR skills also, Imon. She is a graduate faculty at ASU at the Arizona State University. Her research is focused on fairness in AI. We will go deep into that. Multimodal deep learning and AI translation. Uh, her expertise again is in mitigating biases, right? Not just studying biases, but also mitigating biases in multimodal AI systems. Her research explores ways to ensure that AI models are not only accurate, but also equitable, addressing concerns related to race, gender, and other demographic factors. And she's currently leading multiple federal and non-federal research grants aimed at advancing AI to support digital healthcare. Thank you, Imon, for joining. Means a lot.
Thank you for invitation.
No, not at all. So, Imon, we typically start these sessions by asking our guest to describe what they do as if they were telling a 5-year-old. So I know you have a 2-year-old, you just mentioned.
That's right.
But yeah, what is it that you do? What is your research?
So it's my research is kind of like coming from the computer science background because you understand, right? Like I work in a medical field, but has a background in computer science. So it's interesting, but not easy because you have to be a kind of like bridge between the medical people and the computer science people. And this position actually give me a unique opportunity because I have the access to Mayo Clinic as well as the ASU, Arizona State University, which is one of the largest engineering schools. So you can imagine that this creates me that kind of like a bridge to work with engineers as well as computer science, like theoretical side as well as on the medical side. So this brings me in a unique position. So we work on a lot of topics in biomedical, computer visions, then natural language processing, AI bias, and everything. And the whole idea is that you understand, right? That currently the problem is that we have a lot of data. The first challenge we face that people are keep complaining that oh, medicine does not have data, my medicine does not have data, but that is not true. Medicine has a lot of data, but they are all kind of like locked behind the firewall. So that is the primary problem, that collaboration is always difficult, right? So but fortunately, given in this position, we have a lot of collaboration. So whenever we develop model, we start like kind of validating outside the institution. But what we found is that it's not easy when you train the model on a single institution and try start validating on another institution which has a kind of separate demographic, separate comorbidities, which changes a lot, and most of the time the model does not generalize that well. So we are working from the engineering side more on the computational debiasing. So where we start doing the debiasing with like some kind of algorithmic approach so that we don't face that challenge of model generalization. So we, in that sense, we are also working on anomaly detection. So again, unsupervised. So before, even if we don't have access to the data, what we do is that we send some kind of Docker container so that we can clean the data without even
Hmm.
seeing the data before we run the model and generate the results. And then the next step, what we are working on is like kind of like multimodal data integration. So we do a lot of like multimodal embedding, visual language model, so that we can create a kind of integration between multiple data elements for medical diagnosis and prognosis.
Imon, one and very, very fundamental question. Uh, why are machine learning models, deep learning models, why do they have bias? Like, first and
Right,
foremost, how do you define bias, right? What is bias?
right,
And is there a certain threshold that a model has to cross uh, in terms of performance difference for you to call it bias? Right?
right,
Like
right.
if a model is 89% sensitive versus 90% sensitive, would you call that bias, or 80 to 90 or 40 to 90? What is bias and why does it exist?
Right. So that's a very interesting question actually. So I still remember that I was in SPI and I received this one of the question from FDA person, and his question was right, that okay, so you are saying that you are doing debiasing, that means will you bring the majority population performance down? And that, but
Oh,
don't you think that that is
wow.
going against ethics, that you are, okay, you are improving the performance of the minority patient population, but you are bringing down the majority patient population
Hmm.
performance? And I think it's kind of like a right thing to think about, that okay, we want to make the all the model performance equalized across all the subpopulation, but that does not mean that we want to hurt the performance, the model baseline performance on the majority population. So imagine that your model was primarily
No, but
trained on an
Imon,
Indian.
sorry, I'm going to cut you. What is bias again? Sorry.
Okay. So bias is that when you get a different performance across different subgroup. So imagine that your majority population is, you train a model on only on Indian population, right? And now
Yeah,
you want to try this model on a Hispanic population, and
yeah.
you see that your model still working well on Indian population, what you expected. So your initial, like, your test performance was like zero point 0.8 AUC. So when you validate the model on an external population within an Indian hospital, the performance is still zero point 0.8 or zero point 0.7, right? So okay, so you know that the model generalized well. Then you come to US and you validate the population on Hispanic outpatient population, and you see that the performance dropped from zero point 0.8 to zero point 0.6.
Hmm.
So that is the bias, but the cause of the bias is unknown. So you cannot only say that, oh, it's because of the population shift, or it's because of the machine, or it's because of some comorbidities that the Indian population does not have but the Hispanic population has. So the bias can be known as well as unknown. So that makes the bias solve like more challenging, because
Hmm.
if you always know the cause of the bias, then you can solve it. But most of the time in medicine we don't know the cause of the bias. It's people, whenever we say bias, people always have this kind of imagination that it's always racial bias, but it's not true.
Hmm. Yeah.
It can be racial bias, can be age bias, can be comorbidity bias, it can be any type of bias.
Can
So
be equipment,
bias
right? You
means,
have a Philips machine, you have a GE machine.
yeah, it can be image acquisition bias, it can be device bias, it can be anything,
Hmm.
right? So you just want equalized performance across different patient populations. So a new patient comes in, you don't want to say that our model is not going to work for that patient, without knowing that what is the cause of failure.
But Imon, tell me one thing, like, where do you draw the line? Where do you, like, you said zero point 0.8 is very good generalization, zero point 0.7 is good generalization, zero point 0.6 is bias, is like
Right,
lack of bias, actually, I would say,
right.
biased against, right? So, is there a way, like, is there a statistical metric or something where you like
Yes.
statistically significant? How does that work?
Yeah. So we usually follow the disparity matrix. So
Hmm.
where we create a kind of ratio between the targeted population with the reference population. That is usually our majority population in our internal validation. So when the performance stays within zero point 0.8 to 1.2, we call it 20% rule. So it's like plus minus like two standard deviation. So if it is going beyond that plus minus two standard deviation, then we call that the model is bias.
I see. Interesting. And yeah, do you? put a lens of like clinical implications of the two standard deviations? Like for example, uh if your model is predicting, say, size of lung cancer, right?
Mm-hmm.
There even a 20% deviation can mean a lot,
It's a lot, yeah. But you
right?
understand, right? It's not like 20% in terms of measurement. It's
I know, it's
20%
20% in terms of distribution. Uh,
distribution. Yeah, it's
yeah.
20% in terms of distribution. So you are going 20% out of distribution. So then we consider it
Hmm.
as a bias. But you are right that most of the time for measurement, the same approach does not work.
Yeah.
So when I'm giving you the example of the disparity matrix is primary for the prognostic and diagnostic
Classification.
task.
Yeah.
Yeah.
Yeah. Yeah. For classification mostly, right? Like,
Classification or the prediction, so you are doing a survival analysis or something like
God.
classification or prediction.
Got it. Got it. So, and uh, one is the sources of bias, but
Hmm.
technically speaking, like, are there not, like, when you are training a model, like, don't you do like data normalization or like stuff like that, like, uh, to kind of remove bias, or like, why does bias exist? Is it
Right.
because, yeah, why does bias exist? I don't want to kind of.
So you imagine like if we can kind of like take a bird's eye view of the
Hmm.
machine learning or deep learning model development, we can broadly divide that into three steps, right? One is
Hmm.
our dataset curation. Second is our model training. Third is our model like model presentation, right? Like when you actually show the model performance or when you actually display the model to the clinician who is actually your end
Hmm.
user, right? So the bias can introduce in any of these steps. So when the bias is introduced during the dataset curation, we call it data
Hmm.
bias. When the bias is introduced during the model training, we call it model bias. When the bias is introduced during the presentation, we call it presentation bias. Because you know, right, like there can be also a presentation bias that we as a developer, we never think of.
What,
Because you
like, give me
present
an
the
example. This is very fascinating. Yeah,
yeah,
presentation
so
bias.
you for example, like we as a developer, we think, oh, GradCam works pretty well, right? Yeah, it shows me that exactly where I want to look at, and it's showing me the model is looking at that location, so GradCam works pretty well. Or when we are training a vision language model like or a VIT model like a vision
Yeah,
transformer model, we show them that yeah, look, so the model attention is in this area.
yeah.
So as a developer, makes perfect sense to me. So probably it will make sense to clinician. You show them, so they forgot about all the model prediction. They forgot about the model probability. They forgot about the model score. They only focus on that visualization, and think that oh, the model is not looking at the right location, so probably the model is wrong. So this call is kind of like a
Oh, so
presentation bias,
it's like
that how
almost
you
like a.
present your data to the clinician that can also introduce bias, you understand?
Oh, wow. So what you're saying is that it's almost a, at the presentation level, it's almost a psychological phenomena,
Psychological bias. Yeah, exactly,
right?
it's kind of
That
like a more
you get so drawn to the, like, if there are three things the model is showing, you focus only on the wrong thing it is showing, and
right.
thereby you disregard the right
Disregard the rest of the thing that the model is
information.
you have to understand the purpose of the model. Like the purpose of the model is not to generate the visualization. The purpose of the model is to generate some kind of score or
Because
generate some kind of
not sure, Imon,
segmentation.
if you know, like, at CARPL, we had published a paper a couple of years ago. We called it clinical explainability failure.
Yeah, yeah,
Right.
I know that. Yeah, yeah,
Basically, where we were studying only, and we, I think, were biased because we ignored the classification output and only focused
right,
on the explainability part of it.
right.
That
Right.
is.
And that's why I as a developer, I sometimes I'm a bit like cautious when I
Yeah,
put any kind of interpretability to the model,
yeah,
because I think that creates another type of bias, that we are never prepared for.
yeah, yeah.
Because interpretability
And
is so important from the development side for
the
the model
problem is
validation
that
side.
you are actually reducing the dimensionality of the interpretation to be able to cater to like people, right?
Right, right.
And in that you don't know what is getting lost.
Right, right,
So
right.
fascinating, yeah. So
Yeah.
one question, you mentioned computational debiasing, right? uh what is that at training, or so I'll ask you a very simple question, right? Maybe not simple, but question. Can you debias a model, or can you reduce bias in a model without touching the weights, etc.? Like if I give you a locked Docker container, you put in a DICOM, you get out a probability estimate, and let's say this model does not work well on a certain type of population. right? And we find that out by testing. Is it possible to somehow debias a model like that?
Yeah, so that we call calibration, where we add like
Hmm.
another layer on top of the model without touching the original model weight. So primarily in our lab, we are working on three different type of debiasing technique. One is called adversarial debiasing,
Yeah.
where you are actually penalize the model for learning any kind of sensitive attributes, but that you have to do during the model training or during the model fine tuning. So you have to have access to the model weight, so you cannot do the adversarial debiasing without having access to the model weights.
Yeah.
But
Yeah.
adversarial debiasing in one sense is good, in one sense is problematic, because you have to exactly know what are the sensitive attributes that you are debiasing for. So you know
Hmm.
that, okay, the model is failed for like older patient, so I'm only going to debias for older patient. At least you understand, right? This is not a straightforward decision to make,
Hmm.
because most of the time these bias factors like confounders, they're kind of like correlated to each other, they are not independent. So mathematically it's very difficult to like separate them completely. Then there is another type of debiasing that we call causal debiasing. So
Hmm.
where we are actually learning the causal relationship between the actual targeted task and your confounders. So causal debiasing can also be two types. One is known debiasing and one is unknown debiasing. Where you don't know the factor for debiasing, but you are using some kind of proxy to represent them without
Hmm.
really knowing that they have 100% correlation with your actual debias factor. Then there is another type of debiasing that we are currently trying, that is kind of like contrastive debiasing, where we have started showing the different subclass example, as well as with some cases where the model makes consistent failure with this contrastive debiasing. So causal debiasing, contrastive debiasing, we are also doing it without changing the model weight. So we keep the model, like imagine like it's a foundation model. We keep the model, foundation model backbone frozen. But
I got
what
it.
we are
And you
doing,
create like layers on top, and
layers on top of that just for
hmm.
the calibration of the prediction.
And it can that can be both at input and output level, right? Like I
Yes,
can
that can
make
also be input and output level.
like
You can
this for
actually calibrate the input to make it more suitable to the
yeah.
input that the model is
It's
expecting.
like I could make a your example. I could make a Hispanic X-ray look like a Indian X-ray
Right,
before I send it into that model, and thereby
right.
increase the. Ah, that is fascinating. I hope my team people are listening. Like we should build something like this. Yeah, it's amazing. We've got a bunch of questions in Imon. Like I said, I can keep asking you stuff like this for hours. So one very, very relevant question I'm going to take first is from Hasna El Haji. They ask, why not, which is the question I also had, why not develop models tailored to each population separately? Why
Yeah,
is there
that's a
a
very,
need
very
for a
interesting question.
single
And
debiased model that works universally?
we receive this question a lot, you
Yeah.
know. So why you are doing all these computational things for doing the debiasing while you can develop separate model for separate population, you
Yeah.
know?
Yeah.
But you understand that it is not possible, because as a developer, we most of the time we don't have any control on data, right? So
Mm.
we get the data whatever we can. And if we now started separating the data into small, small subportion based on all these different subpopulation, the data set becomes so small, it's impossible to train a model.
No, and I can give you a much simpler answer also, Hasna. You will need those many FDA approvals for your for
That's,
your AI.
that's a good point too.
Right. No, it's
Yeah.
it's true. It's true. If you end up having, one Caucasian model, one Hispanic model, one Asian model, one, whatever model, and that is just one dimension of race, right? Then you have one GE model, one Philips model, one whatever Hologic model, one,
Right,
you will
right,
just end up having so many models, and then all of them will need, $500,000 to get FDA approval, and that's a real practical issue. So if you can
right.
create like layers on top, I think that can be very, very powerful. Yeah, like that's
And
incredible.
particularly with this foundation model, like because I think many of the people probably already know that our domain is shifting. So we have to be
Hmm.
ready for that. That within few years, I don't think that you would have a separate model for separate things. You have to
Hmm.
combine this model to a more generic one that can do multiple tasks together. At least we'll have a common backbone, right? And which makes perfect sense, right? Now our data set is increasing, our powers, like the computational powers are increasing. So we have to start shifting towards the foundation model
Yeah, and in fact,
backbones.
we've got a related follow-up question from Tanmay Sarkar, who asks, why not fine-tune the global model for each subpopulation? It
Yeah,
solves
that's
the
a
small population issue.
yeah. So, but you understand that is not about the population. Because I can give you an
Population is
example
one
that
factor that we know, right? Like
exactly,
it
it's
can be
what
anything
factor we
else.
know, but there are something
It
that
could be
completely. So I will give you an example. So we were working with a colon cancer survival analysis where we get the data from the clinical trial, which includes 12 big institutions across the globe, including Australia, New Zealand, like really like outside US, inside US. This is a big data set. And they all follow the same protocol for capturing the image, same machine, okay, they have slightly population drift in terms of survival, right? But that we expect that Mayo patient survival versus like another completely different patient survival will not be the same, right? Because their treatment pattern is different, the patient population is different. So we expect that change. But when we start taking the foundation model backbone and start applying those for survival model, we can clearly see that the model is performing very good on some population, not good on other population. Then we think that okay,
But
probably it's
what
because
is Iman, what is your opinion of having a like a metadata input into the model?
so we
Purely.
always do that, Vidur. We always do that. So that's we call like proxy.
Hmm.
So we always put some kind of site specific information in the model, Site
No, but
specific information in the sense
in the
that,
model, like, is it when you say in the model, is it like part of the training or you mean like a filter?
as I said, like here all the examples that I'm giving, these are all foundation model.
Hmm.
So these were like pre-trained models. So during training, we are not really giving any metadata. But during the fine tuning for a specific downstream task, we always give some metadata in addition to the
Interesting,
actual
interesting.
images. Yeah.
And in fact, we've got a question from Dr. Suresh Mukherjee. Thank you, Suresh, for joining. One of the legends of neuroradiology, living legends. He asks, can you leverage transfer learning of current data sets from companies looking at similar diseases to help reduce bias? So I guess, if I may paraphrase, maybe you take other companies, or like if a company is say an algo developer, you take similar algorithms and do some kind of leverage them to reduce bias, or something like that.
Yeah, I think that is a very interesting point because I think now also I don't know about like other countries, but at least in US, I think they are following a kind of strange approach that they bring the companies inside any kind of healthcare system. They validate their model and then they stop there. But I don't think that is the correct approach. That oh, you validate their model and you see that the model is not performing that well, I will stop there. But that should not be the approach. It should be a co-development. Co-development means
Yeah.
that okay, the company brings a product and you know that the product has some flaws and you help them to co-develop together so
No,
that you
either
know that
that,
you are
Imon,
increasing the
or I
generalization.
have an even more basic approach where I try to, wherever we are deployed, we try to advise that you do the validation and you
Right,
figure out guardrails, right?
right.
That this model does not work on uh,
Some
people
specific cases.
between the age of 18 and 24.
Right,
What,
right,
you figure out like some specific metadata attribute and then you
right,
don't run it on that. Simple. It's like,
right.
at least you are deriving the benefit on
At
something.
least if you don't want to use your data to fine tune the model, at
Yeah.
least let the company know that these are the cases where it
Yeah.
consistently fails. So you guys should look at that.
Yeah.
It's not like, oh, I validated it, it did not work, let's stop it there.
No, we've got another question, Imon, in from my colleague Sankalp. He asks, recently read about synthetic data. Does training the model on synthetic data, which might include more diverse data sets, help in overcoming bias?
Right. So this is a very interesting point that I think synthetic data has two parts, right? One is that we use synthetic data because many people don't have access to the original patient data. But you should not forget the fact that synthetic data actually generated from the original distribution. So you should not expect that when you generate a synthetic data from your original distribution, it will go and generate completely different thing. It will represent your original distribution until you push the synthetic data to generate from the boundaries,
Yes,
where you
correct.
have
Yes.
kind of like a fuzzy boundary between subclass or something. Until that, just generating synthetic data with GAN or with diffusion is not gonna give you something which is completely different than your original data.
But Iman, we do have the advantage, right, where we can have one example of a
Mhm.
rare case or something like that and generate many more examples of that. Of course, the problem I see is people don't actually look at those images with their eyes, right? Or
No,
people
but
who
you
are
understand
looking
it's
at
the
those
same
images.
thing, right? Imagine
Yeah.
that you are. So, what is the problem with the majority, majority undersampling and minority oversampling, right? So, you are just creating the redundant data
Sorry,
that should
sorry, one
work too.
second. Majority
Undersampling,
undersampling and minority
minority
oversampling,
oversampling,
and exactly, I get it now. So you're artificially increasing the prevalence
artificially
of,
increasing that, right?
yeah, yeah, yeah.
But that does not always work because again, the same thing, right? You are taking the data from the original distribution. You are just creating replicate copy of the data, but the model is not really getting any new information. Okay, synthetic data probably
Hmm.
creating a little bit more variation compared to the just the minorities oversampling, but it's not going to solve your problem completely.
Hmm. Very interesting. Yeah, amazing. Like yeah. I'm actually thinking on the fly. Then we have a question from another of my colleagues, Shashank. When you were mentioning bias, right? You said data bias, training bias, presentation bias, or data bias, model bias, presentation bias. He asks, can you please share examples of data bias and training bias as well?
Right. So sharing bias, one thing I feel like what I'm like observing again and again with the students, with the colleagues, that they imagine like they've trained a model successfully on one use case, and that model performed really well. They did a comparison with all the other model, and then they got stuck with that model. They don't want to change that. They keep using the same model again and again and again and again for every task. I think that is a kind of like more like developer bias, that I like that model, I'm going to apply it, that also creates some kind of like training bias, because okay, you are like the model, it's okay, but you should keep thinking about what architecture is suitable for your task. It's not like, for example, in one task you apply swing transformer and you get a good result. That does not mean that swing transformer is going to work for all the other cases, right? Because it works with the image pyramid. So you can think about that when your findings are of different size, different kind of like attribute, then probably the swing transform is going to work. But for example, if you are going with P detection, probably the swing transform is not going to work because it's always small, right? But I think it's kind of like a developer bias that
That
they
is
like it,
so
they would apply
interesting.
it.
It is so, it's, like my key takeaway from today's webinar is that bias is a psychological issue, right?
I
which
think
is
so,
which
yeah.
sounds so obvious now when I'm saying it. Like, bias is a psychological issue. Like, even in
Right,
life it is a psychological issue, but
right,
even in like, this is incredible, right? That you are a developer, you're building a chest x-ray tuberculosis model, you come up with a great architecture, you apply the same thing to pneumothorax where the prevalence is so much lower, or you apply the same thing to prostate cancer, and
right.
because wow, that is no, thanks, Imon, for that. We've got one more question, two more questions, wow, that have come in. Is there any way we can add confidence levels for each prediction? This is from Tanmay again. For example, can a model be more confident for white population and less confident for a minority population? So I think
Yeah, that's a very, very good point actually with the confidence. But you understand, right? I personally feel like we are also interpreting the confidence in a different way, because most of the people think that, oh, we are getting a probability score, that is our confidence.
Hmm.
But probability score is not a confidence because it's not properly calibrated.
Yeah, yeah,
So
yeah,
you have to, when you want to use the probability score as your model confidence, so you have to calibrate it so that it represents the confidence. But people are also using some kind of entropy optimization or something like that also to represent the model confidence. There are different ways of doing that, but I think it's a good direction to go. But you understand, like, this is not come in the training phase. It's more on
yeah,
the presentation phase,
yeah.
because this is kind of like a
Yeah. Yeah.
representing the
And
model,
you can't actually overburden the clinician
right,
with,
with a
first
lot of
you're
different
saying,
metrics.
you are
You
saying,
you
you
know
are saying,
better than anyone.
there is 35% probability of there being 67% probability of there being
Right.
cancer. So
Right.
I think
Yeah.
it's but great question. We are at time, so we'll just take one question here from an anonymous attendee. Sorry, Shashank, I will answer your question separately online. We'll get Imon. But if one is validating an AI's performance and it is not up to the mark, how easy is it to say that it is because of bias?
You
I think this
understand?
is a
I
great
again
question.
the same thing. I don't know. I don't like this approach that people, whenever the model does not perform well, the people think that it is bias.
Yeah, yeah,
It is not
yeah,
always bias. Model that cannot perform well because it's simply it's overfitted.
yeah. Yeah.
So you
Yeah.
just have to solve that from the overfitting side, not always because of the bias.
Mm.
So
So you can't hide behind bias, both as a
you
model
cannot
developer.
hide behind bias. I
Yeah.
keep checking papers. I keep checking the FDA disclosure. They say like
Yeah.
it's bias, 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 but it's not bias. It's just like simple way of solving the model training, right? Like yeah.
No, wonderful. Thank you so much, Imon. We try to
Thank
stick
you,
to
Vidya.
time. Thank you so much. And wow, this was my like